So now we are live on YouTube as well as this. So we just went live now, and we're going to broadcast in a minute or two.
We're broadcasting in 5, 4, 3.
Good evening, everybody. Welcome to our weekly conference from University of Miami in Cerebrovascular and Skull Base. This is our 14th session on the Thursdays. I'm Jacques Morcos, professor and co-chair of the Department of Neurosurgery and director of Cerebrovascular and Skull Base. And my co-directors for this course have been and continue to be Carolina Benjamin, partner, assistant professor specializing in brain tumor and skull-based surgery, director of our Keynes cadaveric lab. Mike Ivan, assistant professor, director of research of Brain Tumor Initiative, specializing in brain tumor, skull-based, and epilepsy surgery. My two endovascular, open vascular partners, Bobby Stark, Eric Peterson, in both co-directors of endovascular neurosurgery. It's been a wonderful series of lectures, thanks to you participants who have been continuously coming week after week. We're of course broadcasting from lovely Miami. Our two main hospitals are University of Miami Hospital, Jackson Memorial Hospital. We started back May 21. This is a series of lectures that we have done, we have gone through, and we are here today on August 20th. Housekeeping instructions for tonight. Participants, in the Q&A box, you can see at the bottom, please send your questions. We will address essentially all of them by the end of the session today. We are not offering CMEs. You will get a confirmatory email that you attended this in case it's important to you. If you like these sessions, please share the information on your social media. I don't think I'll have a problem today, but I'd like my speakers to stick to about 25 minutes each, so we can have plenty of time for interactive discussions. I would like the audience to please send me suggestions for topics in cerebrovascular and skull base, or speakers they would like to hear. And I'm happy to take this into consideration as I prepare the next session, or the next series of sessions into September, October, November, and probably through the end of 2020, given where we still are with the COVID situation. My email, my Twitter. I'd like to tell you that next week, for example, we have a fantastic panel on sinonasal cancers from Franco Di Monte on a neurosurgical perspective, and Zuka Sarji, my partner here, from rhinology and head and neck surgery, the rhinologist perspective, with an outstanding panel with Albert Kim, Jim Liu, Pablo Recinos, and Mita Shah. So please join us. In parallel to this talk, to this series on Thursdays, we also, Mike Ivan, my partner, runs a fantastic Wednesday symposium, the Miami Global Brain Tumor Symposium. And next week, don't miss Mike McDermott, who will give an update on meningioma next Wednesday at 5 p.m. Many thanks to the team that makes it happen, Ingrid, Roberto, Cristina, and particularly Ignacio Escalona, who runs this webinar every week. Again, this is the link and various addresses you may be interested in. We're happy to answer any questions you have, Instagram, Twitter, so forth, for our department. Let me introduce our wonderful panelists today. I'll start with Rose Du, professor of neurosurgery at the Brigham at Harvard Medical School. Rose, thank you for joining us. Rose is a spectacular open vascular surgeon who has now trained into endovascular as well with her partner Ali Sultan. And Rose, it's fantastic to have you to discuss a case today. My wonderful friend from Cali, Colombia, Alfredo Pedroza Campo, professor of neurosurgery at Universidad del Valle. As he will tell you, he is actually the scientific chair for the next World Congress of the WFNS, and he'll make sure to invite you all to participate a year from now in Bogota, Colombia. And Alfredo is duly trained, did his in open vascular and endovascular, did his endovascular fellowship with Der Brugge in Toronto. Next is Henry Wu, professor and vice chair of neurosurgery at North Shore University in Manhasset, also duly trained, wonderful friend, spectacular researcher and clinician in endovascular and open vascular, and one of the best well-dressed people in neurosurgery. Well, perhaps has a competition from Pascal Jabour, who's next. But anyway, Henry, thank you for joining us. Last but not least, my compatriot, Pascal Jabour, who is absolute star of neurosurgery, both open and endovascular, professor of neurosurgery at Thomas Jefferson in Philadelphia. So you can see we have a fantastic panel, and I'll introduce the two speakers. First is Greg Zipfel, who is Ralph Dacey Professor and Chair of Neurosurgery at WashU. Did his residency in Gainesville, did his fellowship here with us in Miami, Cerebrovascular and Skull Base, about 17 years ago, is co-director of Stroke and Cerebrovascular Center at Barnes Jewish Hospital. Of course, Greg is a world expert in stroke, cerebrovascular, and skull-based tumors. His research has many fronts, but particularly the molecular basis of subarachnoid hemorrhage, how the brain is injured, vascular dementia, dural AV fistulae, which is also one of the reasons he's here speaking to us today. He has had continuous NIH funding since 2005, 2 R-level grants, and many other distinctions that this slide cannot absolutely contain. He continues to have multiple roles in organized neurosurgery, and of course, highly deserved. But Greg, as I said, was my fellow 17 years ago, and it's one of those encounters before he did his fellowship. I could immediately recognize a star in the making even before he started his fellowship with me. And I and many other people certainly were not wrong in predicting this. A true surgeon scientist, a really rare breed in our midst. And Greg will discuss with you his work in dural AV fistulae. And second is my friend for decades now, Luca Regli, professor and chair, Department of Neurosurgery, University of Hospital in Zurich. Luca did his MD in University of Lausanne, residency there with Nicolas de Tribole. You can see a young de Tribole picture there. I know Luca has learned a lot from Nick, and they remain wonderful friends. He did his fellowship at Mayo Clinic in Rochester. He was chair in Utrecht for about 4 years before becoming chair in Zurich. Of course, he follows in the footsteps of Yazergil, who you can see here, as well as Yonekawa and Bertalanffy. Luca has made tremendous contributions to the field in cerebral ischemia, homeostasis, brain edema, surgical techniques for bypass surgery, intraoperative imaging, very well published as well. His clinical practice is of complex, complex open vascular surgery. And I will never forget pre-COVID, the wonderful bypass course symposium he did in January. That's probably one of the last trips, international trips many of us have taken. And thank you, Luca, for putting this together and all your other contributions to the field. And without further ado, I will stop talking and I'll invite Greg to start his presentation and share his slide and unmute his microphone. And welcome to all of you.
Thanks so much, Jacques, for the invitation. Does that look okay?
Looks perfect.
Yeah, okay. Well, I really appreciate the invitation. This is one of my favorite topics to talk about. And so I'm looking forward to the next couple of hours and exploring dural AV fistulas, what's new, and hearing from all the other speaker, Luca, as well as the panelists in terms of, new insights and how people are treating this, somewhat rare, but very interesting topic. So thanks so much for the invitation, Jacques. So I'm going to be talking about, I'm going to introduce the topic of dural AV fistulas just to make sure everybody on the line is oriented. And then I'll talk about a lot of natural history data that we've been working on for quite some time, and how I think this data, kind of adapts or kind of leads to, a management schema that makes sense based on the literature. Research finding that has nothing to do with dural AV fistulas. Again, definitions, natural history data. I'm going to introduce this, what we call Condor, which is an international multi-center consortium of which several people on the line are part of, something we developed a few years ago, and it's been a kind of a lot of work getting to where we are, but multiple papers are actually currently under review by JNS and Stroke, and I'm going to share some results from a few of those papers that are coming from this international effort, and then overall some treatment recommendations. So just so we're all on the same page, dural AV fistula is, fed by dural arteries, and typically the artery will, have an abnormal connection directly into a sinus, and so you'll have this shunt from the dural arteries to the dural sinus, and that may or may not involve a cortical vein, and then sometimes the dural artery connects directly into a cortical vein, and a sinus is not directly involved. But when they are present without a sinus, it's often is near a sinus. And then a key piece to understand is, in terms of especially natural history and management, is cortical venous drainage. Some people call it cortical venous reflux. And basically what that references is that there is an abnormal flow of arterial blood from the dural arteries, either through a sinus and then to the cortical vein, or directly into a cortical vein. But ultimately what you have is arterialized cortical venous drainage, and that abnormally high pressure blood in the cortical veins is what leads to much of the symptoms and morbidity and mortality associated with this condition. So cortical venous drainage is what I'll refer to it throughout the talk. These are some slides depicting the most common angiographic classification scheme, the Borden-Schuchart type. I believe that Luca will talk more about classification schemes, and there are other schemes that can be reviewed. But throughout my talk, I'll be simply referring to them as Borden-Schuchart type 1, which is what you, and this is, these are in this review article that we wrote a couple of years ago in stroke. But the type 1s is we have this is an occipital artery with transosseous feeders going through the dura directly into the transverse sinus. So this is an example of the most common location for a type 1 dural AV fistula. It's type 1 because there is no coracovenous drainage. Same picture, but this time it's a type 2. And here you'll see, again, transosseous feeders involving the dura, then dumping arterialized blood into the sinus. But because of existing stenosis or thrombosis, there is backflow of arterial blood into a coracal vein that you see depicted here. And that means coracovenous drainage, and that makes this a type 2. It has drainage into the sinus as well as into a coracal vein. And this is a type 3 where in a different part of the brain, this is parasagittal region, you have dural arteries running through here with direct connections into a coracal vein and not really involving the sinus at all. So when it's just a dural arteries dumping straight into a coracal vein, that's a type 3 by the Borden-Schuchart scale. And I'll be using that throughout the talk. Another important definition to understand is the symptoms. And there's different ways they're referred to, and I'll just kind of go through how I think of them and some of the other terms that are used. But there are symptoms related to the increased sinus drainage. If you have arterialized blood that's dumping arterialized blood every heartbeat into the sinus, that can lead to symptoms just from that kind of hyperdynamic type of phenomenon. So these are classically tinnitus, which is most common when the fistula is around the transverse sigmoid junction. If you have a special dural fistula involving the cavernous sinus, then that can lead to high pressure in the cavernous sinus and cranial neuropathies leading to orbital phenomena. And these symptoms overall are often referred to as symptoms of increased sinus drainage or benign symptoms, or some people will call them venous hyperdynamic symptoms or VHS. So that's one way that dural AV fistula come to medical attention. Another is if this arterialized blood going into the sinus and or the veins leads to either focal or sometimes global venous hypertension, and that can itself lead to symptoms. These are the aggressive symptoms that we're all worried about, and that includes frank hemorrhage, which can be intracerebral hemorrhage, subarachnoid hemorrhage, or it can be non-hemorrhagic neurological deficits, which is kind of an umbrella term that refers to a whole lot of symptoms that can be referable to either local cortical venous hypertension or global venous hypertension. And then finally, increasingly with the availability and fidelity of MRI, we can find these incidentally quite commonly now. And so that turns out is important in terms of how you manage these patients, whether they have benign symptoms, aggressive symptoms, or if they have been identified incidentally. So with that, let's delve into the natural history data that's available. And then we're going to start with the type 1s, and then the right-hand column or the right corner, you'll always see the type of fistula I'm talking about. But the type 1s are the ones that don't have coracal venous drainage. They can come to medical attention either incidentally or with symptoms of increased sinus drainage like tinnitus. And this is the first paper. This is the Toronto group where they published 68 patients with type 1 fistulas that had about 2 years of follow-up. And what you see here is the event rates are quite low and the morbidity mortality is actually extremely low. An event rate is any new neurologic symptom that develops either worsening or recurrent tinnitus or a non-hemorrhagic neurologic deficit. And you can see that's quite low. And these are annual events rates. And then the bottom one is the overall rate of upconversion. And that term means that a type 1 fistula without cortical venous drainage upconverts to a higher grade fistula with cortical venous drainage. And so here, quite benign natural history from this one paper. And then about 10 years passed, and then a couple of other papers came up. This is our paper from WashU, where we had 23 patients, so a smaller number of patients, but a lot longer follow-up, about 13 years. And what we found was extremely low rates of neurologic events, mortality rates, and we had about a 0.8% annual rate of upconversion to a higher grade, more dangerous fistula. Rose Dew, who's on the line, along with Bradley Gross, published their series of 24 patients at Brigham and had about 2 years of follow-up. And they also had very low event rates. And the most recent data, this is the newest data, comes from a multi-institutional study led by Dr. Gross and had 295 patients from several centers, I believe including Brigham, Pittsburgh, Barrow, and maybe one or two others. And they had about 177 lesion years of follow-up. And again, very, very low event rate. So if you take that natural history data in summary, and now we have quite a bit of data as opposed to maybe 5-7 years ago, the event rates is very low for neurologic events. The mortality rate is 0, and the upconversion to a higher grade fistula is also quite low. Importantly, all upconversions that have been reported in the literature to date have occurred with either a new neurologic symptom, so new tinnitus or recurrent tinnitus or new non-hemorrhagic neurologic deficit or new hemorrhage, or an acute loss of one of those symptoms. So someone who had tinnitus and all of a sudden spontaneously it abruptly is gone. Those are the type of symptoms that suggest that the fistula has changed. And when those have been examined, some of those will have upconverted to a higher grade fistula. So all the reported events of upconversion have occurred in the setting of altered symptoms, positive or negative. So this concludes that really it's a very benign natural history in terms of neurologic morbidity and mortality for type 1 fistula. Now let's move on to the type 2 and 3 fistula. I lumped those together, and I'm sure maybe a little bit later Dr. Du may want to comment on this because she does have some data that suggests that the natural history for type 2s and 3s may be a little bit different. She may want to comment on that. But for me, I generally lump them together, and most of the natural history data we have has lumped them together. It starts with this report from Dufault et al. In 1999, where 20 patients, all of which had presented with aggressive symptoms with hemorrhage, and they only followed them up for 20 days. And what they found is 35% of those patients, while they were awaiting treatment, rebled. So a very morbid natural history. This was followed up by Van Dyke et al. This is a Toronto series, and this is 20 patients, almost all of which were presented with aggressive symptoms, either hemorrhage or non-hemorrhagic neurological deficits. And they either refused surgery or treatment, or they were treated, but the cortical venous drainage remained, and they were followed for 4 years. And what they found were annual event rates of about 15% and mortality rate of 10%. And if those two things combined suggested that the morbidity and mortality of type 2 and 3 fistula, which is very different than type 1s, had a very morbid condition, but actually much worse, if you think about it, than aneurysms and AVMs. And that was back in the early, late 1900s and 1990s and early 2000s. And then about 10 years later, 7, 8, 10 later, a couple of other papers came up. This is our paper from WashU, 28 patients. But importantly, if you remember, almost all these patients in these early studies had presented with hemorrhage or non-hemorrhagic neurological deficits. They were aggressive. But now we're seeing patients where a good number of them are incidental or only have tinnitus. And we wondered if that difference in presentation mattered in terms of natural history. So we followed these patients for 2 years. These are patients who either refused treatment or were treated but still had cortical venous drainage, and we followed them up until the point that they were effectively fully treated. And what you see here is those patients that presented with aggressive symptoms, similar to what the Dufault and Van Dyke series had a very bad morbidity and mortality, 19% annual event rate and a 4% mortality rate. It's very similar, very bad, need to be treated. But if they're benign, if they presented with no symptoms at all or just tinnitus, the natural history is very different. The annual neurologic event rate was only 1.4% per year, and the mortality was 0. And this was statistically significant. And this was this plus the follow-up paper, or another paper published around the exact same time from Soderman et al. Showed that mode of presentation really mattered in terms of what the natural history looked like and should be taken into account in terms of counseling patients in terms of treatment. Soderman et al. Had 85 patients with longer follow-up than we did. They only tracked hemorrhage. They didn't really track non-hemorrhagic neurological deficits, but you'll see here a very big difference in terms of natural history, annual hemorrhage risk, in those who presented with hemorrhage versus those that did not. Later, Bolters et al. Had a study that was interesting in that they identified venous ectasia, so a dilatation of the arterialized cortical vein, as a risk factor specific to poor natural history. And that was followed up by the Gross and Du publication in 2012, where they again saw that aggressive symptoms increased the risk of or worsen the natural history over time. But they also found that venous ectasia seem to also impact natural history. So now 2 papers have suggested that venous ectasia is important for natural history, as well as now mode of presentation in several publications. And the newest data is, again, that multi-institutional study from Gross et al., where they had a number of type 2 and 3 dural AV fistulas. Some of the type 3 fistulas had venous ectasia. You can see the time of follow-up in each of those categories. Again, almost 300 patients in follow-up. And what they found is that if you had benign symptoms or no symptoms, that the natural history was relatively benign as compared to if you had aggressive symptoms. Now, it's still a serious thing. 1.5 to 2.5% chance of a hemorrhage or non-hemorrhagic neurological deficits in patients with type 2 and 3 fistula is not something to be ignored. That's significant risk, but it's very different than the risk associated with those who presented with non-hemorrhagic neurological deficits or those who presented with hemorrhage. And you can see it's interesting, those who had non-hemorrhagic neurological deficits, almost all of their subsequent events were worsening of those deficits, while those who presented with hemorrhage, almost all of the events that happened in the future were hemorrhagic events. But those are bad actors. So in summary, for type 2 and 3 fistula, if you present with benign symptoms or no symptoms, your natural history is very different than if you present with aggressive symptoms, and you see the numbers there. And venous ectasia also seems to, in 2 publications, to be a significant risk factor for worse natural history. And this really says that mode of presentation and venous ectasia can be used to help refine risk stratification when you're counseling patients. All right, I'm gonna shift to Condor, which is this consortium that we've been working on for the past 3 or 4 years, putting all this data together. And it took quite a while, but we now have a nice data set. And I'll just share some of that with you. Here are all the centers that are participating. Here are all the PIs that are representing their institutions, and Miami is well represented, as well as some of the other speakers on this symposium. I want to particularly call out Dr. Radima Gunaganti, who's a 3rd-year resident here at WashU, who this was her project as a 1-year research fellowship with me, and has continued as she transitioned from medical school to fellowship. So a lot of this work is really predicated on her efforts. This is just a description paper of the formation of Condor and kind of the rationale, design, and some descriptive statistics on the series. This will be coming out in Journal of Neurosurgery in the next few months, I suspect. In the Condor, there's about over 1,000 patients from 16 centers. It's all retrospective data. There's no prospective data here. You see the time frame in which these patients were identified. All the patients had angiographically confirmed dural AV fistulas. We had a whole bunch of clinical and radiographic variables that we collected from all these centers. This just describes what we have. We've got 370 dural AV fistulas, almost all of which presented with benign symptoms. 66% of them were treated, and you see how they were treated there. About 73% of them were cured angiographically, and the morbidity rate, permanent morbidity rate associated with treatment was quite low. The type 2 fistulas, there's 174 of those. About 40% of them present with aggressive symptoms. Almost all of them underwent treatment, and about 75% of them were cured. And the permanent neurologic morbidity grossly was about 5% in this patient population. And then the type 3 dural AV fistulas, which are by far the most common, about 60% of those patients presented with aggressive symptoms. Almost all were treated, and the cure rate was approaching 85%, with a 3% permanent neurologic morbidity rate, all comers. With this database, we have 9 ongoing clinical studies and a whole lot of other ideas we have in terms of how to utilize this data set. And I'm going to share with you three projects that have come out. All of these are under review or in revision with either Stroke or the Journal of Neurosurgery. The first comes from UVA. Now, this is Jason Sheehan and his group utilizing this database. And they wanted to look at observation as a treatment approach versus intervention, and we'll define what that means in a second, for low-grade dural AV fistulas, those without cortical venous drainage. And again, these were not, randomized or any kind of protocolized way. This was individual surgeons deciding in terms of and recommending observation versus treatment for their low-grade dural AV fistula patients, and then after the fact, going back and looking at the results for the observed arm versus those that were treated. You see that about two-thirds of the patients were treated and about 125 were observed. Importantly, in this data set, CC fistulas, which are a subtype of dural AV fistulas that are unique, are included in the analysis. And I'll talk about that in a second. They use primary outcome measures of modified Rankin scale. The secondary, I think, is the most interesting. They look at modified Rankin scale mortality and cure rates, but they also look at symptom improvement. And again, the main indication for type 1 fistulas to treat them is because of intractable symptoms. So you really want to hone in on, does treatment effectively treat the symptoms? They did a statistical analysis, as you see listed there. The results are as follows. In the unmatched cohort, that means all comers, if you compare those that were observed versus those that were treated, there were no differences in the primary outcome as by modified Rankin scale, and there were no differences in secondary outcomes, including symptom resolution. The only difference is the angiographic cure rates, and you can see the difference there. Now, they did a propensity matched analysis to really match up patients, so they were, comparing apples to apples. And when you did that, you got a very similar result. There were no differences in symptom progression or symptom resolution, whether they were treated or not, in this analysis. And then if you look only at the symptomatic patients, again, no differences. And importantly, the procedural complication rate, all comers, were 19%. Now, again, the permanent neurologic morbidity was low, about 2%. But the point is this, that based on this kind of analysis, there isn't compelling data to be treating these low-grade dural AV fistulas on any routine basis. The obliteration rates are higher, but the symptomatic improvement rates are not demonstrably higher with this kind of analysis. And so really doesn't provide evidence to support the routine treatment of low-grade dural AV fistulas. And in my mind, and I'll talk about at the end, what this means is you got to be select in terms of what patients who have type 1 fistulas you're treating. And they really need to be medically, life-altering intractable symptoms to offer them treatment, because there is some morbidity, and the data doesn't support that you're really dramatically improving their outcome in substantial ways. Now, this is, again, there are a lot of caveats to this because it's not a protocolized approach, it's not prospective, it's not randomized, but some data that put some pause on our treatment of low-grade dural AV fistulas. The second paper comes out of Iowa, and again, looking at low-grade dural AV fistulas, a little bit more of a description paper, but also did some analysis on outcomes, and I'll share it with you, and it's a little bit different in terms of how they went about it, and the results are a little bit different than what I just showed you. A bunch of fistulas, but here they took out the CC fistulas, and that's important. Different endpoint. The primary endpoint included worsening of non-hemorrhagic neurological deficits and those symptoms related to venous hyperdynamics, the benign symptoms, tinnitus. Complication rates, again, the permanent neurologic sequelae are pretty low. If you present with older age, non-hemorrhagic neurological symptoms or severe hyperdynamic symptoms, you had worse outcome, meaning you had, the resolution of those presenting symptoms were not always there. They didn't see any significant difference in improvement or stabilization of symptoms in the conservative treated versus the treated cases. That's similar to UVA. But here they did an estimated survival analysis, and here there was a trend, not statistically significant, that patients that were treated, especially those that had a complete occlusion of their fistula, that they did do better in terms of their symptoms. So the conclusion from this is that the therapeutic modalities for low-grade dural AV fistulas are safe, and they may provide some symptom control, but not definitive and not really strong evidence that we should be treating these in any kind of routine way. The last one I wanted to share with you comes from Jason Sheehan, again from UVA. This time we're looking at unruptured high-grade fistula, those that have coracovenous venous drainage. Here's those that were treated and those that were not. And importantly, the observed arm is pretty small. So you have to take that into account in terms of this analysis. The methods were similar to their first paper. And what you found here are as follows. If the patients were treated with embolization or with surgery, their chance of cure rate was higher than if they were observed. Makes sense. The mortality, all-cause mortality, was lower in the embolization group than versus those that were conservatively treated. There was a trend towards that with surgery as well, but the numbers are not as great, which potentially impacted the significance. For hemorrhage, the hemorrhage rate was statistically significantly lower if they had been embolized versus if they had been observed. And there was a trend similarly with surgery and radiosurgery for less hemorrhage than if they are conservatively treated. The non-hemorrhagic neurological deficits, however, were no difference between the two groups. The conclusions here are that embolization and surgery are better at curing the lesion than observation alone, that embolization reduces death and reduces the risk of hemorrhage, and there are trends for the same with surgery. And this study supports embolization as the first-line treatment of choice for appropriately selected unruptured type 2 and 3 fistulas. So different than type 1s, I would say this is data that is preparing a pretty firm foundation that intervening even in unruptured type 2 and 3 fistulas is the right thing to do in most patients. So my last couple of slides, treatment recommendations. Type 1s, if the patient is truly intractable and their life is altered by the symptoms that they have, that is when intervention may be indicated. If you're going to treat, I think the new data from Iowa suggests that if you're going to treat, you really should try to occlude the entire lesion if you're going to try to improve symptoms. And that's the first data that really suggests that. I think a lot of places will palliate and reduce flow to improve symptoms, but long term, it may be best if you try to cure it. And then the clinical follow-up is necessary, like we talked about. CC fistulas, I didn't have a lot of time to talk about, but I will say that all the CC fistulas that were in our series were treated because they were symptomatic, and the vast majority of the symptoms improved. I think there is relatively decent data that says that CC fistulas in general, when symptomatic, should be treated. Type 2 and 3 fistulas, if you have aggressive symptoms, they should be treated, and they should be treated early. If you have benign symptoms, but you have venous ectasia, like the example to the top right, I think the data suggests that they should be treated, and they should be treated early. However, if you have benign symptoms and no venous ectasia, the natural history is more benign. And therefore, I think more elective treatments for a lot of patients is reasonable. And I think even radiosurgery or even observation for select patients would be reasonable, where I don't think those with venous ectasia or with those with aggressive symptoms, that would be reasonable. And with that, I'll close and take any questions or pause for the next speaker, whatever Jacques wants to do. Thank you.
Thank you so much, Greg. The amount of work, of course, you've put into this is obviously paying off, and I salute you for all the efforts in trying to help us understand. I normally don't do questions at this point, but I see a question from the audience, which is probably the right time to ask you now, from Dr. Eitan Raz. The follow-up for the GROWTH study, was it based on imaging or just clinical? Do you know? Do you remember the GROWTH study that you mentioned?
I will let Dr. Du answer that, since she was part of that study. How about that?
Yeah.
It was all clinical, actually.
Clinical, wasn't it? Okay.
It was, well, the clinical, if there are symptoms, then the patients will get imaging, but if they remain asymptomatic, they don't necessarily get follow-up angiograms.
Okay. Back to you, Greg. Do you consider tinnitus always a benign symptom? Are you lumping it always as a benign symptom? The audience is, well, Dr. Raz suggesting that tinnitus is not always a benign symptom. It can be quite disabling. Does that factor into what?
Yeah, I think it's a nomenclature thing. Benign symptom, to me, it can be very debilitating. Absolutely. To me, why it's often referred to in the literature, and I often refer to it as well as benign, is that the chance of it doesn't have anything to do with increasing the risk of a hemorrhage or a non-hemorrhagic neurological deficit like seizure or focal deficit, although the symptom itself can be quite debilitating. And the same thing with orbital phenomena related to a CC fistula, that can be very debilitating, but it doesn't increase your risk of having a hemorrhage or a serious focal neurological deficit.
Okay. I think I'll invite Luca to speak now. If you could share your slides, Luca, and tell us if you think differently about how to classify those things, and perhaps how does that well, after you discuss your classification, how do we factor in all the previous publications into your classification and all the interesting questions that relate to that? Go ahead.
Okay.
And welcome, well, and thank you for being up so late just to share this with us.
Well, thank you very much, Jacques. It's a great honor and a great pleasure to be part of this. So maybe you can let me know if you can see the screen.
Very well.
Okay, great. Let me just, okay, yes, so it's a great topic, and I think it's a great honor also to follow Greg. Great talk, by the way, Greg, and fantastic data and fantastic effort. Yes, so I was going to maybe introduce a slightly different view on the classification. And first thing I want to say is that this work is really mainly the work of Anton Valavanis. I mean, it's a lifetime expert of endovascular, and he has spent a lot of efforts in understanding the diseases and trying to simplify, or not necessarily simplify, but really understand the disease from an angiographic point of view. And Balsavias has helped writing this, and obviously Peter Roth has done the drawings. So it's no financial or material disclosure for this from my side, sorry. And so cranial dural AVFs, this is also going to be today's talk, short overview. Very short over classification systems because, you know, everybody knows the Borden and Cognard, and then trying to introduce the DES, so directness, exclusivity, and strain classification system, which is what Valavanis developed, and try also then to bring it to implication for treatment, not about treating yes or no, but more maybe microsurgery or endovascular, and some take-home messages at the end. So, at the start, you know, why do we even use classification systems in general? This is really very general, but it's kind of, it has to be easy and practical. It has to favor the way we communicate among us, and it has to help for research. It was a great example of the talk before of Greg. I mean, how important it is to have classification system when you do research. It also has to reflect the disease entity and be precise. For the user, well, first of all, we have to apply it correctly. So we have to understand the classification system. And at the end, as any coding system, it necessarily has limitations. So there's no way we can reflect the complexity of a disease, the complexity of our patients presenting to us with just like 3 categories or even more complex like Cognard or the one I'm going to illustrate. So it's a coding system. And, oh, I'm sorry, really going always the wrong way. So dural AV fistula, just I'm going to retake some anatomical basis. You really need to only know 3 things. There is a dural sinus, a venous dural sinus, which obviously is enveloped in dura. There may be emissary veins, so which go from the interior to the exterior. And there are the bridging veins. So the bridging vein or the leptomeningeal or the cortical veins that bridge from the brain to the dura. And the foot of this bridging vein really is a dural structure. Now, once we have this very basic anatomical understanding, to understand the fistula, we only have to add one thing, which are the arteries. It's the dural arteries. So we add the dural arteries, and then you have a shunt there, and you've got the dural AV fistula. So you've got an acquired lesion, a high flow, low resistance lesion. And the shunt location, really, it's all about understanding the way, and to understand also this classification is not to understand what you see most on some of those angiograms, which are scary when you see them. It's to understand where is the exact location of the shunt, of the fistula of the shunt. And then you heard a lot about it already. It's the leptomeningeal venous drainage, also called cortical venous reflux, which will influence the clinical behavior. And then venous strain. Venous strain is venous ectasia, but also venous congestion. So you may have aneurysms, you may have aneurysmatic dilatations, but we also have venous strain if we have congestion. The clinical behavior of patients who have venous congestion is also very different from those who do not have. So coming back to this basic principle, where can you find cranial dural arteriovenous fistulas? It's everywhere where you have a dural sinus and bridging veins. So you have them along the sagittal sinus, you can have them along the inferior sagittal sinus, you can have them in the temporal fossa, sphenoparietal, cavernous sinus, superior petrosal, inferior petrosal. So this region you can have it because you have venous sinuses, you have bridging veins. You can have it on the superior surface of the tentorium, because you have the tentorial lakes. You also have, again, the petrous sinus. You have the transverse sinus. You have the torcular, and you have bridging veins there. And don't forget the tentorium has a lot of those structures. You have the inferior surface of the tentorium, which would be this illustration, having, again, the same anatomical predisposing condition. You have the inferior, the posterior fossa, which obviously, again, the transverse sinus, the sigmoid sinus. You have the whole basilar or clival venous connections, the petrous sinus. And interesting enough, in the frontal fossa, in the anterior fossa, you have the classic structure, foramen caecum, and you have the sagittal sinus, so you can have fistulas, dural arteriovenous fistulas there. And you have one exception in the whole head, which is the olfactory region, where you do not have the classic dural venous sinus, but you can have fistulas, and you have direct kind of durocortical connections. And this is actually almost similar to what we find in the spinal cord with dural AV fistula of the spinal cord, where there is direct connections without the dural sinus. So the olfactory cribriform region is the exception where you have it and you don't have the dural sinus. So this is, again, the conditions to find it. The Borden classification, again, fantastic presentation before, really looks at one thing, which is the venous drainage in the sinus and the venous drainage in the cortical bridging vein, if you want to say so. And it has very simple 3 things. Interesting enough, it does not consider at all strain, ectasias, or venous strain. But it looks actually mainly at the cortical reflux and of the venous drainage in the sinus. Now, the much more complex, we have the Cognard classification, which not only looks at a cortical venous reflux, but gives a lot of importance to the antegrade and the retrograde flow, and does add some interesting point, which is the venous ectasia to the category 4, and also gives importance to the perimedullary drainage, or which are patients who have myelopathy. Now here, interesting enough, the limitation is it kind of considers that, like type 2, do not have venous ectasia, because venous ectasia only is described for category 3, which is the ones that have CVR only, which would be the venous Borden 3. Again, so a lot of importance on the venous drainage in the sinus, not so much venous strain. There is some part of venous ectasia, but no congestion of the veins. A lot of importance on the retrograde flow on the sinus, which is clinically actually not so relevant, except some very special situations. Also important to understand that the Borden classification, for example, the isolated sinus shunt is defined as a Borden 3, which is very different from actually a direct drainage into the bridging vein shunts. So the classification, they did not consider venous strain. They anticipate that there is no venous ectasia in grade 2s. And there really is no differentiation between drainage exclusively in a bridging vein or also into a sinus, and really doesn't really distinguish if the drainage is directly into the bridging vein or into the sinus, and then secondarily into the bridging vein. So these are those limitations that kind of explain the category or the classification, which I'm going to try to illustrate now. So important to understand for the classification now, which again, it has been published in 4 papers, consecutive papers by Valavanis and Balsavius, is that I'm only going to talk about patients or AV fistulas that do have leptomeningeal venous drainage. So we do not talk about the grade 1s. And so the ones that we already heard clinically are very stable and very rarely have actually threatening symptoms. The second thing is to understand that the shunt, it's really all about where the primary shunt is located. And so the shunt really can be only in two places. It's either in the wall of the sinus itself, and then we call it dural sinus shunt, or it's at the foot of the bridging vein, and then we call it a bridging vein shunt. And let's forget for this presentation the emissary vein shunt, which is also something one can see, but we'll keep it to the bridging vein shunt and dural sinus shunt. And again, remember, we're really talking about all these have leptomeningeal venous drainage or cortical venous reflux, because that is the essential feature that determines aggressive nature of the shunt. So it really splits into three things one analyzes. It's the directness of the shunt, it's the exclusivity of the venous drainage, and it's the signs of strain that the cortical veins have due to the retrograde flow, again, leptomeningeal venous drainage. So let's start with the directness. Let's take this illustration here. Very clearly, you can see that the shunt, the arteries do shunt, the arteriovenous shunt is in the wall of the dural sinus. So it is called a non-direct shunt because the center of our thinking is the bridging vein foot. So that would be the dural sinus shunt. It shunts into the sinus, and the vein has a secondary reflux into the bridging vein. So it is not a direct shunting into the bridging vein foot, which would be different for this patient. This patient has a direct shunt at the foot of the bridging vein. So this is called a bridging vein shunt or a direct shunt. That's for the first thing. And I think this is absolutely essential when you see this complex angiogram to really pinpoint down where is the primary shunt and not where is the secondary reflux. That is the second thing you have to figure out. And that's called the exclusivity of the drainage. So again, because we only talking about patients who have a leptomeningeal venous drainage, the exclusivity, all of them have reflux, cortical venous reflux, again, LVD. So when it's exclusive, so this patient will be indirect, it's a dural sinus shunt, but it exclusively drains through the bridging vein or the cortical venous reflux because there is thrombosis and closure of the venous of the dural sinus. So this would be exclusive drainage through the bridging vein. Well, this patient still has the same shunting point. It is a dural sinus shunt, but it drains through both. The dural sinus has arterialized blood and the venous obviously has arterialized reflux. So this would be non-exclusive and this one would be exclusive. And then we look at strain. And strain is not only ectasia, it's not only aneurysm, but it's also congestion. And again, easily illustrated here, this patient has retrograde flow. It's a direct shunting on the bridging vein foot. It has, it has direct flow into the vein, has a little bit maybe in the sinus, but has no strain. And this patient has a lot of strain. So this is as simple as that to understand the pathology, and it has consequences on the treatment and I think also on the natural history. So some examples here. If we look at this patient, one clearly recognizes a dural sinus. So this is sigmoid. We have here transverse is probably almost occluded, but transverse, a little bit of transverse sigmoid. venous here. We have the arteries. Those are always very impressive. But you do see here two little structures which are cortical veins. So there is venous sinus, there is cortical veins, and actually this one is probably the inferior petrosal sinus. So you even have some drainage here. And then you have to figure out the shunt. The first point of the shunt was in the sinus. So it's a Borden type 2 because it's in it has sinus drainage, but it also has reflux. It's a Cognard type 2AB. And for the other classification, yes, it does have leptomeningeal venous reflux. You see here two temporal veins. The first point of the shunt is not directly to the bridging vein, but it's through the sinus, so it's into the sinus. So it's a dural sinus shunt, and it's not exclusive because it drains both, and there is no strain on these veins. So that's how we would classify it. It's actually very descriptive. Now this patient, we recognize again here a dural sinus structure. Again, the arteries, we don't even talk about the arteries almost. So it's really about the veins and where the shunting is. And then we have a big vein of Labbé with clearly some dilatation and congestion signs here. So here again, I don't show you the dynamics, but the first point of the shunt, you see it here, was into the wall of the dural sinus. And then there is reflux and you have clearly strain. So you have strain from the cortical reflux. It's non-exclusive because actually I have to show you this. You see on the AP that there is some flow from the sinus or to the other side. So it definitely is not only through the vein of Labbé, it also drains through the sinuses. So it's a non-direct dural sinus shunt. It's not exclusive because it drains in both the sinus and the cortical veins and has a lot of strain. And then if we look at this one here, again, another situation. Here we have also again a sinus. Again, it's a dural sinus shunt, but you don't see any drainage through the sinus. So it's thrombosed. This would be what also is called an isolated sinus shunt. So by definition, it's a type 3 Borden, which still is very different than this, which is a type 2. And you have a lot of congestion in this whole temporal venous region. And now another illustration here. I mean, you only have one picture, but you have the shunting is here. This is actually really the petrosal vein. We do not see any direct filling or even close filling of the superior petrosal sinus. So it's a direct bridging vein shunt. It directly goes into the foot of the petrosal vein. This would be the petrosal sinus is the connection with the shunting is close, is thrombosed. So there is no arterialized blood in the venous petrosal sinus. There is a sinus here, but this is secondarily retrograde through the vein. So this does not count. This is the straight sinus. So this is a direct shunt on the bridging vein. It's exclusively draining through the bridging vein, retrograde, and it has no strain. This vein looks pretty not strained. And so this would be a Borden 3. And again, remember, this also is a Borden 3. And if you look at these two pictures, completely different fistulas, but still the same Borden type. And this now also Borden type 3, we already can see that there's a big difference between these Borden 3s. So we had 3 Borden 3s that are completely different in anatomy. So this one though, interesting enough, this is not, so this is actually the sphenoid wing. This would be actually, this is a anterior frontal middle vein going into the Rosenthal and then back to the straight sinus. So it would be actually a connection, could have a connection with the sphenoparietal sinus. So it is a dural arteriovenous fistula. And it is directly into, we don't see any sinus structure here. So it's a direct bridging vein shunt. It's exclusively draining through the bridging vein. And this clearly has strain, ectasia in the anatomy of the veins. So this one is BVS, bridging vein shunt. It's exclusively draining and has strain. And again, just as a reminder, all the three we just saw are Borden 3 according to a Borden classification. And the Cognard is very complex. And I think, you know, a retrograde flow into the sinus really doesn't have the importance if you look as isolated only in the retrograde flow. Now, interesting, there are 211 patients that Valavanis treated over 19 years. 107 of those patients had corticovenous reflux. And if we apply this classification and the Borden, we see, interesting enough, you see the green is benign behavior. And the red, the dark red really is the most aggressive, is hemorrhage. Now, interesting enough, the only difference between the first three, you see it's repeating itself. Dural sinus shunt, isolated sinus shunt, bridging vein shunt. And then here again, the difference between the three is these three had venous strain. Strain, yes, strain, yes, strain, yes. These three are the ones who had no strain. No strain, no venous strain, no venous strain. And so you can see that it actually repeats the same order from aggressiveness of the clinical behavior, or the benign, reversed for the benign behavior between dural sinus, isolated sinus, and direct bridging vein shunt. But if you take these conditions and add venous strain, all of the three will have a more aggressive behavior. And still, the bridging vein shunt, so the direct shunting into the bridging vein, is much more aggressive than the isolated sinus shunt, also if both have strain. So this is what these categories did show. So there is some utility in classifying it according to this. Now, for the surgical candidates, one could say, well, what about, are all the patients who have leptomeningeal venous drainage, cortical venous reflux, would those all be good candidates for surgery? And you already can answer no, because I mean, these two patients both have leptomeningeal venous drainage, but obviously absolutely not the same thing to treat one on the right or the one on the left. One is a bridging vein shunt, Borden 3, other Borden 2, dural sinus shunt. So no, just looking at the veins is not enough to understand which ones are the best candidates. One could say, yeah, but then maybe all the Borden 3s could be good surgical candidates. And again, here, both these patients are Borden 3 by definition of the Borden classification. But one is, if we take the anatomy again, the shunt, the primary shunt, the arteriovenous shunt is here, again on the petrosal vein. And this is a direct bridging vein shunt with all the strain, whereas this patient has shunting into the sinus and much more complex venous situation. Typically, the ones that drain into the sinus have several veins draining. They often are bilateral. They can be supratentorial and infratentorial veins. So much more complex surgical procedure than just interrupting a direct bridging vein shunt. And again, both are Borden 3. So Borden alone will not distinguish between good surgical candidates and more complex surgical candidates. And you know, this patient, we did a classic treatment for that. We do believe that bridging vein shunts are ideal candidate for microsurgical treatment. And you know, you only have to interrupt the vein, because there is one single vein where the foot of that vein at the bridging vein, that's where the shunt is. And so you have to interrupt that. And it's really a burr hole surgery. So this is the approach that you do to interrupt this fistula. Very straightforward, extremely safe and efficient. It is interrupted. And we looked at over 12 months, 20 patients that were analyzed, 6 had LVD. And, you know, we have a philosophy still of primary embolization, but we did find out that bridging vein shunts, so the direct shunting on the foot, are really the ones that ended up having more frequently complete treatment with, this is complete result, with microsurgery. Some, it can also be embolized, and the other ones are not ideal candidates for surgery. So what we take out of this, even in an area where we have a philosophy of primary treatment with endovascular, there are some of these fistulas, some of these patients who really are ideal candidates for microsurgery. And those are the ones that we need to identify. And this classification really helped in making it pretty straightforward to identify very easily which ones are the ideal candidates, at least in the first approach. And if we take again the basics of the classification, I'm just going to repeat it once. I know I said it several times already, but it's the directness. So it's either a bridging vein shunt or a dural sinus shunt. It cannot be anything else. It has to be one of those two. And again, the difference here illustrated very clearly. After that, you do analyze, obviously, the venous flow, and you try to figure out if there is still some flow through a sinus. So here, this one would have flow through both the vein and the sinus, or if it's exclusively through the bridging vein. And very important for the clinical behavior and the decision-making, are there any venous strain? And the venous strain is not only ectasia, it's not only aneurysms, it's also congestion. And that's how you put it together. Now, the aggressiveness, there was a correlation. In a way, the aggressive natural history depends on the venous outflow restriction, because if you have thrombosis, there will be more strain on the draining veins. So in a way, one can say that the aggressiveness of the natural history depends on the exclusivity and the venous strain, which are two of the three things that one classifies in this category. So aggressive natural history, exclusive yes, no, venous strain, and the treatment decision on surgery or endovascular as primary could really depend on where the primary shunt is. Is it a dural sinus shunt or is it a bridging vein shunt? So there is really implication of clinical decision-making for it. Again, the difference between is it direct or is it indirect? And so this is what we believe now. It's treatment option. If there's no LVD, it's conservative. If the leptomeningeal venous drainage is direct, is non-direct, so in the shunt is on the dura and of the sinus, then it's primarily clearly endovascular, because these patients almost always have multiple veins that drain. Again, can be bilateral, can be supratentorial, infratentorial. So it will never be a straightforward mini craniotomy. You will have to do a very large approach to get that by microsurgery. Whereas, and that's the thing, whereas if it is a bridging vein shunt with a direct shunting there, the microsurgical approach is extremely focused and a limited approach that is very efficient in interrupting these shunts. And these bridging vein shunts, in our experience in the clinics, is a very distinct group with the corticovenous reflux. And they actually were the largest group in our clinical experience of the patients who had cortical venous reflux or leptomeningeal venous drainage. So more than 50% of all the patients who had LVD had actually a bridging vein shunt. And so we believe that those are ideal surgical candidates. So thank you very much.
Thanks, Luca, very much. Very clear, very thorough. If you could stop sharing your slides. Just a quick question before I invite the panelists, Luca. The D and the exclusivity, the directness and exclusivity, you are not suggesting that they are completely independent variables, are you? Obviously not.
Well,
the D and the E.
Yeah, well, let's say I didn't show, there are examples of bridging, patients who have a bridging vein shunts where there still is some drainage into the sinus. Those do exist. And so you can really have the full spectrum of the category.
Right.
The clinical experience, however, shows, and it's a hypothesis, that probably those bridging vein shunts really become symptomatic when the connection with the sinus gets thrombosed.
Yeah, I mean, in our experience, I'm sure.
Most of them are exclusive.
Yeah.
Most of the direct are exclusive, but you do see patients, and I just took them out because they are very rare. You do have direct shunts that are non-exclusive.
Right. I'm glad you clarified, that point. Okay. May I invite Alfredo Pedrosa to share his slides and unmute his microphone, Alfredo, and it's your show for the case you want to show.
Okay, thank you, Jack, for the invitation. Wonderful presentation before. No disclosure. Many greetings to the panelists, obviously. I am living here in Cali, Colombia. This is my city. I work in two places, University Hospital, 800 beds, and in the private medical center, CMI. My mentors, neurosurgery staff during my residence, Roberto Heros, Jean Ausman, and Karel Terbroek, with I perform interventional neuroradiology. This is a man 48 years old, cranial trauma 15 years old, bilateral disabled pulsatile tinnitus of greater intensity in the right side for 4 years. Chronic, recurrent, and sometimes severe headache in the bilateral parieto-occipital region with very little response to medical treatment. We can see high intensity area signal voids at the junction of the transverse and sigmoid sinuses area. The angiography MRI showing vascular malformation, suggesting dural fistula. The cerebral angiography, this is the right internal carotid that is normal, except that we can see dominance of the left venous sinuses and some stenosis in the left venous sinuses that we are going to speak later. The right lateral external carotid, we can see dural fistula at junction of transverse and sigmoid sinuses, feeding branches to dural fistula from middle meningeal artery and occipital artery, petrosal branch, and transmastoid branches. Also, we can see a right occipital branch supplying dural fistula to the other side, on the left side. The left internal carotid, we can see recurrent tentorial branch of the inferolateral trunk feeding dural fistula. The left external carotid after occipital artery origin, we can see dural fistula junction of transverse and sigmoid sinuses. We can see feeding branches to dural fistula from middle meningeal artery I'm in posterior medial branch and petrosal branch. This is the left occipital. And we can see occipital transmastoid feeding branches. We can see here the fistula site, no retrograde cortical and sinus venous flow. Site of stenosis in the left transverse and sigmoid sinuses. Here is very clear. And here is very clear too. The vertebrovascular circulation, pial contribution to fistula through branches of the superior cerebellar artery. Case summary, 4 years of disabling bilateral tinnitus of greater intensity on the right side and continuous headache, sometimes very severe. Bilateral dural fistula at the level of the junction of transverse and sigmoid sinuses being greater in the left side. There is no retrograde venous flow. Functional venous sinuses and dominance of the less venous sinuses. Various sites of the stenosis in the left transverse and sigmoid sinuses. What to do? No treatment. Treatment of one or both fistulas. What side do you treat in the case will treat one fistula? What approach? Arterial, venous, or both? How it handles venous sinuses?
Can we, Alfredo? Fantastic case. Let's ask maybe the speakers first, and then the panelist.
Okay.
Is that okay? Yeah, Luca, what do you recommend?
Yeah, I think this is typically the situation where the natural history of this fistula should not be threatening, but the patient is still a young who has invalidating, that's how I understanding, 4 years tinnitus. So it's all about quality of life. And as we heard before, tinnitus can be extremely invalidating. So I do think if this patient cannot handle his tinnitus anymore, one has to consider treatment. I still would think that the localization of the side of the tinnitus because it was a pulsatile tinnitus, if I remember well. So I do think that the fistula is good for it, and not like one could, I was thinking during the case if maybe the stenosis on the left would make a functional overload of the right transverse sinus, that he would have a tinnitus which is not pulsatile. But if the tinnitus is pulsatile, I would, and it's invalidating, I think he needs right-sided fistula, because both fistula are not threatening outside of the tinnitus. And then, as we mentioned before, I definitely think that endovascular would be the way to go.
Do you think
Greg?
sinus stenosis, even though it's in the sinus, is kind of like a venous ectasia or venous stenosis if it was draining cortically, and because of the hypoplastic right-sided transverse sinus, that it would put him at higher risk?
Excellent question. So I definitely do think that it contributes to the concept of venous restriction. However, nature in this patient has not shown any cortical venous reflux. So yeah, we can elaborate and say he may develop it. And there the data of Greg, which he showed that the upgrading of a fistula still is rare. But yeah, I would follow him if he would not be treated. Any change of symptoms, this really we took out of the talks of today. I would even feel comfortable if his symptoms do not change. Greg, essentially you taught us, you proved us that without clinical symptoms, you hardly ever see upgrading of a fistula.
Greg, what are your comments on this case?
Yeah, I mean, I think I largely agree. I mean, I think this you have to really make sure and be impressed that this individual, is really very affected by the tinnitus, and it's altering his life, and I'd want to in person understand that and really get a feel for. It's not just annoying. It's not it's just not something when you lay down and sleep and you hear a little heartbeat in your it's something that really is life altering. So if it's life altering, then I think you can say that that endovascular, this would be endovascular treated almost for sure, and that the results in terms of a permanent neurologic injury are 2 to 3%. So then you have it's life altering, and if you can cure the AV fistula, have a really good chance of getting rid of the symptoms. And as long as they understand the complication rate, I think it'd be reasonable to treat. I think you would be guided by the side of the symptoms. Hopefully it's one side or the other, and you could direct your treatment there. But I think based on some of the data that I presented, we're pretty conservative with these. But when people are really have life altering symptoms, then we do treat. I think the data out of Iowa, to me, changes things a little bit, because they identified that the patients who really seem to have the best longer-term symptom resolution are those where the fistula was completely obliterated by the endovascular treatment. That's a little different. At least the way we treated them before, we would often palliate as long as the flow was reduced and the symptoms got better. We felt pretty good about that. Now, you often went ahead and if it could be done to cure it, but it wasn't the goal of the treatment. But I think the Iowa data suggests that maybe if you're going to treat, you really should treat to cure, because the data suggests that that's the patients that in long-term follow-up had the best long-term resolution of their symptoms. So I think, to me, that changes a little bit. It's just one data point, it's one study, but it changes my approach if you're going to treat.
Pascal, if you were to treat this, is there any role for intraluminal pressure measurements to select which side do you start with, or do you go for the more obvious side? What are your comments on endovascular?
Just to comment a little bit of what Greg just said. I think there's still, sometimes we do palliative treatment. I think it's very important to know our complication rate. And sometimes, especially in this case where we're not worried about cortical venous drainage and we're doing mainly palliative treatment, like mainly to palliate headaches and tinnitus, sometimes going for a complete cure, and it depends. I mean, if we can go for a complete cure, absolutely, the data shows we should go, but we shouldn't just go and try to treat the images. And I think that sometimes there is room for palliative care where you would treat until you have no more symptoms, for the patient doesn't have any more symptoms. At that time, you will decrease your risk. Now, for this patient, I mean, I go by clinical, and depends where the tinnitus, what side is the tinnitus. Looking at the angiogram, of course, I don't have dynamics. It was still pictures. That between transarterial, transvenous, the dual lumen balloons really change the way we treat fistulas. With those balloons, we're able to go. We don't have even to go really distal. You can inflate the balloon and then inject your liquid embolic, and you can push it all the way to the fistulous point. All those arterial feeders are going toward one fistulous point. And if you're able to get into one feeder and push all the way your liquid embolic to the area of the fistulous point, you should be fine. Transvenous, in this case, if we're gonna go, the problem is the right side is a hypoplastic sinus, and we need to be careful. And even in this case, sometimes, it's helpful to inflate a balloon in the sinus to avoid shutting down a dominant sinus where you would reflux your liquid embolic all the way to the sinus. So,
Rose, any comments? You're muted.
Yes, I agree with all the other panelists in that we really should not treat this unless the patient's incapacitated by the symptoms. Having said that, we At our institution, we have treated Borden type 1 fistulas, but very rarely. And again, only if they're truly incapacitated. I would agree though with the endovascular treatment, because if they're incapacitated, that's the quickest way. Radiosurgery would probably take too long if the reason for treatment is the incapacitation.
Alfredo, back to you.
Okay, thank you. We perform transarterial honest embolization of left fistula with transvenous balloon protection of the sinuses. This is the material, Fargo Mini as intermediate catheter, Apollo microcatheter, Onyx 18, and on the transversal balloon protection, Neuromax, the catheter guide, and Copernic balloon 8x80. This is the microcatheter to the posterior meningeal branch. You can see the transvenous Copernic balloon protection. This is the intermediate catheter, Fargo Mini, and this is the tip of the microcatheter in very good position. The balloon was inflated and deflated every 5 minutes to avoid venous infarction. Honest embolization in progress. Honest embolization is over. Left carotid after embolization, complete disappear of the fistula. And after embolization, we perform angiography of the right side of the right external carotid artery. The fistula didn't change. We decided not to embolize this left dural fistula. The pulsatile tinnitus decrease. The patient have a severe headache for 3 weeks with a normal simple CT scan, and then decrease, and at 3 months after the procedure, he had no headache. Control at 8 months, the left internal carotid is normal without fistula. Left external carotid, complete occlusion of the fistula. Angiography of right lateral external carotid, we can see the fistula is still showing the dural fistula with feeding arteries through the middle meningeal arteries and occipital branches. The patient persists with mild left tinnitus and no headache. Do you think anything? What to do?
Can I ask my partner, Bobby Stark? I don't know if, Bobby, you had a chance. Do you want to offer your opinion at this stage? I don't know if you've seen the slides he was showing.
Yeah, it's a great case. And I think really nice use of the Copernicus balloon, nice treatment on the contralateral side. It's too bad that we have to get a FDA exemption to get that balloon in the United States, because it's great for cases like this. I mean, if the patient really has minimal symptoms and no cortical drainage, and it's draining just into the right transverse sinus, you know, I think the natural history of this is fairly benign. I don't think it's that difficult to treat, but if his symptoms are really minimal, I think following it would be a very reasonable and conservative approach.
Anybody else wants to offer advice? Oh, I'm sorry. Let me read the question from the audience, Alfredo. He said, could you show again the right ECA frontal view? It was not obvious that the fistula shown was on the right, but instead filling of the left fistula through posterior meningeal branch. But that's a question of the audience. But clearly what you showed is the fistula was on the right, correct?
Yeah.
Yeah. Okay.
Yes. Do you see?
Yeah.
This is the fistula on the left, and we treat the left fistula.
Yeah, yeah. No, it's clear. It's clear.
Okay.
Back to you. What did you do anything at this stage, or?
No, I agree. We didn't do anything conservative manage, okay, because of the symptoms are very, very light. Last week, 2 years after the procedure, I saw the patient. A year after the procedure, the tinnitus was gone, and he has been asymptomatic for 1 year. Only one question, do you perform any control in this moment or for the future?
So the right fistula is still there, you're physically, angiographically is there. Okay, so the question to panelists and speakers, what would you recommend for the future? Do you do an angiographic control now or ever, or what's anybody would like to offer advice?
The patient is asymptomatic right now.
To me, it sounds like after the procedure, the tinnitus was better, but still present. Is that correct?
Yes.
And then at some point, it's
now it's gone, Greg. The tinnitus is completely gone.
Yeah. So to me, I would say that that's a change in symptoms and would prompt a catheter angiogram to see where you stand. Most likely, the left fistula is completely obliterated, and the right one is still present. But and then if that's the case, then I would just follow them along symptomatically. If this tinnitus ever returns, then you'd want to reevaluate with imaging again, with vascular imaging again. That's the way we would treat it.
So I couldn't tell for sure, but was that left transverse sinus much better after the Copernic balloon was inflated to that degree in that sinus? That's number one. Number two, after about 6 months to a year, all those enlarged vessels will regress in size, and it's much easier to assess the angiography after all of those vessels have decreased in size. So if there was, let's say, a small amount of residual that was left behind that you couldn't see at the time of the procedure because those vessels are so large, you will have a much better idea what is actually still residual after 1 year, and you'll also be able to see what's going on with that right-sided fistula as well. So I would definitely, and the patient definitely needs follow-up MR for sure, and then depending upon what the MR and the angiogram show, would potentially need another angiogram at some point in the future. But it's much easier to assess the fistula angiographically after all those blood vessels have regressed in size.
Okay.
Yeah, I would agree with doing an angiogram. The thing that I would worry the most are actually the patients who have tinnitus and then the tinnitus disappears, because or either one of two things can happen. Either the flow is less, the fistula is gone, or it actually up converted, as Greg had mentioned, occurs in about 3% of type 1 fistulas, into, say, a type 3, in which case they're not going to hear anymore. They may not have any more tinnitus, but in fact, it has become more dangerous.
Greg, can I ask you a question? Do we have any data that would suggest that partial treatment of a type 1 may make it upconvert more likely, or is that entirely theoretical?
I don't think it's, I don't think there's any strong data. I mean, when I say that there's, all the upconversions reported in the literature, we're literally talking about 6 or 7 total cases, last I looked. So, but in that group, there are some that were treated partially and then upconverted. So I think it's an open question, but I think in my mind, I think it's possible that there's a relationship personally, but I don't think the data is at all strong. It's just a hint of it in a few cases that are reported.
Alfredo?
Yes.
No, go ahead. What would you want to carry on with the case, or is that your final slide, or?
I have one question. Is it possible by the time?
I'm sorry? Yeah, sure, go ahead.
Okay. A question to the speakers and the panelists. In the case of transverse sigmoid sinuses, dural fistula, Bowden type 1 and Condor types 1 and 2A, associated with significant stenosis, critical stenosis. What is your opinion of angioplasty, PTA, and stenting of the sinuses as the only treatment? Because there are some reports about that.
Dr. Jabour.
So, I've never done that, and I think in this case we're not treating really the disease. I wouldn't do that.
Henry?
Yeah, actually, I just was able to recruit Athos Patsilidis from New York Hospital to Northwell. And he actually has a pulsatile tinnitus clinic where he will angioplasty and stent transverse sinus stenosis in the presence of pulsatile tinnitus if the pulsatile tinnitus is disabling to the patient, and even in the absence of the fistula. I think that in this case, angioplasty and stenting of the sinus in the presence of the fistula without addressing the fistula transarterially is only going to worsen your pulsatile tinnitus, because you're going to decrease the resistance of on the venous side of the fistula. And unless you take care of at least some of the arterial side, you're probably not going to take care of the pulsatile tinnitus. So if you're going to angioplasty and or stent on the venous side, I think that in the setting of a dural fistula, you have to do something transarterially, or you're going to make things worse, because you're going to basically, increase the flow to the fistula, not necessarily, and make the progression and the natural history of the fistula worse.
Jack?
Yeah, that's it. That's it, Alfredo.
Yeah, no, it's only, I was asking that because there is one report from Riner and Condor that they did 4 cases with PTA and stenting of the sinuses, and reviewed the literature. They used precise stent, 19 cases, angiographic 10 cure and 9 shunt reduction, and clinical result was very good, 11 no symptoms, and 3 symptoms improved. 4, they don't specify what is the result. And I have this due because probably angioplasty and stenting of the sinus could be the only treatment, but only in the type 1 of classification. It's only that. Okay.
Very interesting. So,
Yes.
The assumption will be that the tinnitus is not due to flow, cc per minute, but linear velocity, correct? Since the narrowing of the sinus would have a, per Bernoulli equation would have a higher velocity rather than cc per minute. If that's
Well,
true.
if 10 of them are cured, though, I mean that.
Yeah.
If
Yeah, no, I'm not criticizing. I'm saying.
There must be. I'm trying to understand how they're cured. What's the porosity of the stent that would lead to a cure like that? I don't understand.
Yeah, the porosity of the stent is pretty darn low. So that's why
it's an open cell stent. It's not even a wall stent. It's not it's an open cell. Yeah.
It's an open cell stent with a metal surface area coverage of probably somewhere around 9 to 10%, if that. The reason why it would work is if there are septations in the sinuses, and if the sinus has a septation, and by angioplasty and stenting it, you happen to push one of those septations up against the wall, that's why it would potentially work. But you have no idea of a priori upfront determining whether that septation is there or not, or whether this is going to actually work or not.
Yeah.
Or if you are deforming the sinus, straightening it or deforming it, and then you're shutting down some feeders. It's
but even if you deform the sinus, but if the shunt is still, if the fistula site is still there, you're not gonna.
Or somehow when you deform it, you're changing the architecture and you're compressing or something, like some kind of physical vector force when you change that. Because I cannot explain how 10 were cured.
Yeah, it's hard to explain.
Okay, what do you have to, I would assume on the angioplasty and stenting, they got to be on anticoagulation, while the embolization would not be on anticoagulation too. Is that correct? And I'm wondering if there's any difference in complication rate would you expect with one?
They have to be on dual antiplatelet therapy.
Yeah, right. So it seems like that alone, dual antiplatelets, was going to carry some some risk to patients outside of rather than transarterial embolization.
you know, on the venous stents, especially with these lower surface metal area coverage stents, you can get away with aspirin alone.
I have only 2 cases with only the symptom was very, very bad tinnitus associated with critical stenosis, and the differential of pressure was more than 10 millimeters. And I put a stent, I put wall stent, and the patient was very, very good after the procedure. But it's different because it was only tinnitus without headache and any other symptoms, and without fistula.
Interesting question. I think, Alfredo, we're going to move on to the next speaker. Very, very nice presentation. Thank you so much. Lots of food for thought. Rose, may I invite you to share your slides and unmute your microphone?
Okay. Right. So, so this case, this would be a little bit more interactive because there are many steps that occurred here. So this is a 75-year-old woman who underwent an angiogram really for workup of an aneurysm and was found to have a Borden type 1 fistula. You see here, this is on the right side. The ECA showed that there's middle meningeal feeders and occipital artery feeders. There's also feeders from the meningohypophyseal trunk and the carotid-tympanic artery there, with drainage into the superior petrosal sinus. There's actually also a hint of some drainage into the cavernous sinus too, but the main drainage is basically into the superior petrosal sinus. So with that, I guess my first question is, what would you do? Would you treat this, so asymptomatic Borden 1? Would anyone treat this?
And if you don't answer, it means you're not going to treat it.
No treatment.
So I agree. So that's what we recommended to her. So we did not treat it. She subsequently went to another institution and had it treated. So this is the imaging after the coiling. So there's a coiling done through the middle meningeal artery. So it was a transarterial approach, and you can see the coils there. The coils were basically deposited around there.
Rose, they went through the middle meningeal artery into the venous pouch? That's what they did? Okay.
It seems that that's what they did. So
okay.
Now immediately after, this is immediately after the embolization, there's still, you can still see a tiny hint of drainage into the superior petrosal sinus. So now you have a partially treated fistula. Would anyone, what would you do? Would anyone do anything? Would you do any follow-up or anything at all?
The patient definitely needs follow-up, that's for sure.
With an non-invasive imaging, with an angiogram?
I think you're going to have a hard time seeing this fistula with non-invasive imaging. I mean, I think that you have to look at the high-resolution post-gadolinium images and see if that superior petrosal sinus is lighting up. And if it is lighting up, that means the fistula is not cured. But, you know, we're only seeing a static image. We're not seeing the dynamic angiogram, and we're not seeing the stagnation in the superior petrosal sinus. But if there is significant stagnation, that superior petrosal sinus can thrombose and eventually go away over the course of time.
So let me just make sure I understand this. The patient was asymptomatic. You said no treatment, went elsewhere, got treatment. Now is partially, not completely treated, but there's no cortical venous drainage and the patient is still asymptomatic. Is that correct?
Right.
I would not follow this patient with any invasive or non-invasive imaging unless the symptom arose. I mean, you're kind of
certainly not at age 75, right? Can we ask Luca? Luca, what's your classification here?
Well, actually, no, this is the important thing because this has no cortical venous reflux. It's irrelevant,
Right.
the classification, but it definitely is a dural sinus shunt.
Right.
Well, so she got follow-up imaging. Right now she's still at the other institution. So this is 7 months after the initial coiling. You can still see, now you see that and this goes back to the thing that was brought up earlier about up conversion. So this is a case of partially treated fistula, which is now up converted. Now it's draining out through the petrosal vein into the cerebellar veins. Now would anyone do anything?
Interesting,
This is a reportable case.
Well, but on the other
Absolutely
hand,
a reportable case. Seriously, I mean, this has never been done in the literature.
But this is not natural history.
I agree, but
this patient, and this is pretty obvious if you just think about the physiopathology.
Yeah.
The vena, this is what actually nature sometimes does. It closes the sinus and then it transforms into a cortical venous drainage. They closed the sinus, but the fistula was still there.
Which is why I was asking earlier, up conversion with partial treatment. That's exactly the mechanism you can think of.
And the modality of treatment it's uncommon to go through the fistula into the venous pouch from the arterial side. If you went from the venous side, you would be more efficient in terms of getting the coil mass more densely into that superior petrosal sinus and then eventually causing occlusion from the transarterial side. The branch that also goes to it is the petrosal branch of the middle meningeal artery. So, I can understand using the coils because if you use a liquid embolic, you can hit the facial nerve. But now it's turned it from a benign lesion into a significantly more dangerous lesion.
So Greg, at age 75, what is her natural history now with this angiogram per year?
Yeah, so I mean, it's a little bit of but I mean, yeah. So it's now a type 3 fistula, asymptomatic. It's a little bit of a weird thing because of how it got to that. But if you just accept that it's a type 3 fistula that's asymptomatic, it's about a 1.5 to 2% neurologic event rate per year, meaning either non-hemorrhagic neurological deficits or hemorrhage. And you'd have to have a discussion and find out what physiologically how what their status is. But I would now you're kind of obligated, I think, in some way, unless they are only have a short lifespan or medically infirm, that to treat this.
Why do you say that, Greg? Suppose she had an aneurysm and she's 75, and we quote patients 1% per year with aneurysms, but obviously that's an inflated figure on small aneurysm. But would you treat an aneurysm at 75? You know what I'm saying? Why is that different?
Yeah, but I think an aneurysm is I mean, if you want to say it's a 6 millimeter MCA aneurysm, that's way less than 1% per year. We're talking about 1.5 to 2. It's a legitimate point, and I think an aged patient with a 1.5 to 2% risk of a neurologic event, you gotta have to look what's their life expectancy, what's their comorbidities. But if you could treat this with a morbidity of, if they're going to live for the next 8-10 years, and you could treat this for a permanent neurologic morbidity of 2%, I think there is a case to be made in my mind to treat it. But it would probably be endovascular if possible. If not, radiosurgery. I wouldn't operate on the patient.
Well, so you contradict. Sorry.
I'd like to add one thing here. We really don't know what's the natural history of upgraded fistulas, really. I mean, because I think there's a big difference between this fistula that a year ago was nothing dangerous, and then we upgraded it like we woke up a beast, as compared to a fistula presenting already with this that's been there for a while also. So to me, this is aggressive.
Luca, Greg wants to treat it endovascularly, but according to your presentation, this is a microsurgical case, correct?
Well, I would still have Rose. Can you tell us, I mean, is it going first into the sinus still or directly into those veins?
Well, it's actually, and this picture doesn't quite do it justice, but it's actually going to both. So at this point, it's still a type 2, not from the internal carotid artery injection, but you could see from the external injection that it's
So-
going to both.
So
See,
there
then
has to be a
I would definitely agree with Greg, because essentially what we would do with surgery would be, yeah, I mean, we could still plug the sinus and so on and so forth, but I think it's not primarily surgery, this one, because there's several veins coming out of that sinus probably, and not only one vein.
The number one, there is no good endovascular solution to this. So from the pictures that are being shown here, the vessels that are transarterially supplying the fistula, that petrosal branch, I think that there's a significant risk for facial palsy. The carotid-tympanic is not going to go. And the occipital artery is so tortuous, you would be embolizing from such a proximal location. There is virtually no way that you can push the liquid embolic, even with the newer balloon catheters, into the fistulous point. So the two surgical options are, number one, a pre-sigmoid approach to the superior petrosal sinus and pack the sinus with Surgicel or Surgiflow. That's one. Or B, identify with cone beam CT angiography where that sinus drains into the vein, and then do like a retrosigmoid approach, and then disconnect the draining vein from the superior petrosal sinus into the cerebellar veins. But given that—
Can I address that for a second?
Yeah.
There's actually a very nice paper out of Toronto where they looked at selective disruption of cortical venous drainage in type 2 and 3 dural AV fistulas.
Yeah.
Where even if the fistula is not cured, but you have eliminated the cortical venous drainage surgically, that you've protected them against future hemorrhagic and non-hemorrhagic neurologic sepsis.
You
So
converted from like a type 3 or type 2 down to a type 1, and
right. And there's I mean, it's not prospective, third party adjudicated, but it's pretty good evidence that you doing that is very effective at eliminating or virtually eliminating that risk.
I think that is the surgical options for this patient, but given the fact that she is 75, obviously it's a little bit problematic. We've also been using cone beam CT angiography with intraarterial injections for radiosurgery. The target of this thing is going to be 4 millimeters. It's going to require just a single 4 millimeter shot with gamma knife radiosurgery, and the morbidity is almost zero during the course of the lifetime of this patient. And I think that that has also a very high rate of obliteration. And so I would recommend that this patient, if the patient was young, could consider surgery, but now at 75, my first choice would be stereotactic gamma knife radiosurgery with cone beam CT angiography for localization, because you need to make sure that 4 millimeter shot is in exactly the right place.
Rose, one question.
Yes, Alfredo, I was going to ask you to comment.
I see very well the feeding artery of the petrosal branch. I'm not sure if we have feeding artery from the occipital artery, and I think the fistula point is around the coils, and I was thinking about that the previous speaker about the possibility of gamma knife, because it's very clear where is the fistula point, and is really too short to have a gamma knife. If I don't have gamma knife, for me, endovascular, it's going to be very, very difficult. And the second option was surgical approach. Tell me, Rose, do you see some arteries from some small arteries from the occipital?
The issue with the Gamma knife is going to be localization, because your target is going to be very small. And if you miss by 1 or 2 millimeters, then you're going to have, you're not going to effectively treat the fistula, and your obliteration rate is going to go down, which is why, in addition to MR, and obviously with MRI, there's the inherent susceptibility artifact of the coil mass itself. I would also use cone beam intra-arterial cone beam CT angiography, so that way you have a much higher, the spatial resolution of cone beam CT angiography, you can actually get down to like 60 microns, and the beam hardening artifact is less than with traditional CT angiography, and it would allow you, give you the best opportunity to target the shunting fistula site.
I don't think that on those 2 still pictures, we are able to judge if this patient is a candidate for embolization or not, really. Henry, can you tell just from those 2 pictures that the patient is not? We need to look at more, you know, especially in a 75-year-old patient that we're trying to be less invasive.
Is there another big feeder that's going to it? I probably doubt it.
Yeah, I don't know, but
the petrosal branch, yes, they were supposedly in. Then they went through the petrosal branch.
Is there anything contralateral? Is there anything leading?
Nothing contralateral.
The only other, really truly the only thing would be transvenous, and hope that you get to the coil mass in the superior petrosal sinus, and fill it more completely with either coils or a liquid embolic in order to do it endovascularly. That's the only other endovascular avenue that you have available to you. But radiosurgery, I mean, the patient's asymptomatic now. The radiosurgery it's an outpatient procedure. They don't even have to be in the hospital. And as long as you feel that you can effectively localize the fistulous point, there's very, very little morbidity associated with it.
Okay, just for the sake of time, Rose, tell us what you did.
Well, she still hasn't gotten to me yet. This is so
okay.
long. So she's still at the other institution. So they went to the occipital artery and onyx. They did an onyx embolization. As you can tell, it didn't quite get all the way to the fistula site. So this is sort of a pedicle embolization.
Hey, Rose, you need to tell us where the other institution is.
Not show me the pictures before.
This feels like, I think this was treated at Northwell, I think. So that's what I think is happening.
So,
No, the first time was Wash U. The second time was Northwell.
I like that, Jacques.
I would say, unfortunately, this is incredibly common. I mean, we see this on almost a weekly basis. I wouldn't be surprised if the next picture you're going to show us the petrosal branch completely filled with onyx, and now the patient has a facial. And
so no, it's not quite that bad. So she's still intact, and we don't have the middle pictures, but sometime in the next few months, she apparently went back for another embolization, and now they coiled off the middle meningeal. And this is the picture about 11 months after the initial coiling. Still abortin type 2. So this is kind of where we were when we were discussing the last time. And just to summarize, it's just coils there.
Rose, I do see an aneurysm clip. I assume that the aneurysm that was clipped is completely unrelated to this.
Completely unrelated. This is from before.
The other thing too is, why would you coil off the frontal and pretrascomosal, the frontal branches of the middle meningeal artery, and not coil off the petrosal branch that supplies the actual fistula? I mean,
can you go back one slide?
But the coils are in the anterior branch of the middle meningeal artery, and they don't even come down to the foramen spinosum. And at the level of foramen spinosum, you can see clearly the petrosal branch draining out into that residual fistula. And you can see that, you know, the beginning portion of that superior, and it's actually looking like that fistula is actually getting worse and is recruiting more blood supply for the middle meningeal artery. And actually, you have exacerbated the situation because you're forcing blood flow now into the fistula because you've decreased the resistance bed to the rest of the dura.
So just for the sake of time, so now she comes back to us and just had a diagnostic angiogram. So now the fistula has converted to just a type 3 fistula. So things are getting worse. Now what would you do with all those these coilings and glue and things in place? Would you do anything differently from what we were discussing?
I think they probably will have the same opinion, Rose. Nothing has, yeah.
So, so I understanding that she's 75, you know, the risk of hemorrhage, I know there's new data saying that if they're asymptomatic, it's quite low, but I think in this case where the fistula seems to be progressing and also not knowing the asymptomatic results at that time, this is a few years ago, we would consider this fistula to have a 6 to 7% hemorrhage rate per year. So I actually ended up taking her to the old operating room and basically just coagulating the petrosal vein through a retrosigmoid approach. In addition, I just happened to cut the tutorium too, although I think that's not necessary. And this is the post-op angio, and she's doing fine. That's sort of the end of the case.
Yeah, and very nice. I mean, again, to remind people in the audience, this is actually a very, very well done, but very nice surgical approach. I mean, you know, as compared sometimes to the complex endovascular options, if the patient can tolerate general anesthetic. But very interesting case to discuss. Just for the sake of time, I don't want to keep you guys very late. So Henry, thank you, Rose. Henry, let's move on to your case.
Can I just emphasize though, I mean, this is just an example of absolutely, I mean, my God.
Yeah, isn't it?
Should not have been treated, should not have been touched. And then look what happened, you know, multiple procedures and ultimately a craniotomy that was indicated, but would never have needed to be done if this wasn't maltreated. I mean, that's really unconscionable.
Yeah. And you never know if it's poor understanding of the disease process or just let's treat an X-ray. You know, that's what is seen over and over. You can click on play, yeah?
You guys can see my slides?
Yeah, but you're in navigation mode. You should click play.
How's that?
Yeah, perfect.
Okay. So, Jacques, thanks again. I will try to make this quick in the interest of time.
Click on your power, yeah, and then click on that slide, then advance.
Click on what?
I mean, you're trying to advance and it's not advancing.
Yeah.
Left click on like that. Yeah, here you go.
So this is a 79-year-old male, no significant past medical history. And all he has is just bilateral red-eye numbness and blurry vision for the past couple months. He saw his ophthalmologist. The ophthalmologist measured his intraocular pressures, which were, you know, not very elevated, but then he eventually sent him for an MRI, and which showed this, which showed signal, obviously, in the arterial system and in the carotid arteries in the cavernous segment, but it also shows elevated time of flight signal in the cavernous sinus, in particular on the left side. So this led to an angiogram. And so on the angiogram, the ophthalmic artery, the recurrent meningeal branch of the ophthalmic artery, goes and supplies a left cavernous carotid fistula. On the right is a selective injection of the left ascending pharyngeal artery. And on this is an injection of the left external carotid artery. On the slide before, you saw that the superior pharyngeal branch went to it. And here the accessory meningeal artery is now supplying this left-sided cavernous fistula, which goes across the circular sinus into the other fistula, into the contralateral cavernous sinus, and also now drains out both superior ophthalmic veins, which is why he has bilateral redness and conjunctivitis as opposed to just unilateral conjunctivitis, which is classic for cavernous sinus dural fistulas. And then I think my computer froze. I'm sorry. Let me get out of this for a second. Huh? Yeah, I'm completely frozen. Jacques, you there?
Yeah, I'm here. Just wait. What do you think? You can
Yeah,
retrieve?
my computer is froze. It's not moving forward.
You know what? Oh, you can't even unshare your slides. We could have Pascal go while you're trying to fix yours. Would you?
Yeah, but
Or
I
do
mean,
you want to carry, or do you want to? You need the pictures, I guess, to ask the question.
well, so at this point now,
Yeah.
The issue is, treat the fistula, don't treat the fistula, and if you do treat the fistula, I think you have enough information to know, what the arterial anatomy is. You can see that there's drainage inferiorly in the clival venous plexus from the cavernous sinus, et cetera, et cetera.
Yeah.
There is reflux into the Sylvian venous system. The Sylvian venous system also, there's no like real significant venous ectasia or significant venous stenosis on the venous system. I'm going to log in via on my phone, and then I'm going to reboot my computer.
Yeah, and I've asked Ignacio to unshare your screen. Ignacio, go ahead if you can unshare his screen.
I'm trying, doctor.
No.
It's not working. Stop sharing. Nope. I really don't know what happened. Something happened to his computer. It's not letting me.
Right. Doesn't let you access it.
No, it says stop participant sharing, and it's not doing anything, doctor.
And it's because my computer's frozen. So I'm gonna turn off.
If you turn it off completely, I wonder if it stops sharing. I assume it does.
Yeah, it will stop as long as he's connected to the mic, to the phone. He should be good. So you can shut off the computer.
Henry, you hacked the system.
Yeah.
I'm telling you, it's a Northwell thing. It's just torture. It's beyond belief. The IT system here is crazy. All right, so I'm on my phone now, and I'm rebooting my computer. And if you guys want to have a discussion about potential treatment, that's fine. If you guys want to have a discussion, if you want to move on to Pascal's case, and then I'll come back to mine eventually, that's fine with me too.
Yeah, no, I think we can do Pascal's case, but we just need to unfreeze your slides to be able to, for him to show his.
So my computer is now off, and
yeah, got it. Yeah, thank you. It unshared.
Yeah.
Well, no, so let's discuss your case. Maybe we don't have to show the rest of the images since it's complicated. You just go ahead, ask whoever you want to ask. Rose, maybe? Rose, do you want to comment on those images that he had?
Yeah, I see that there's also the superior-ophthalmic vein draining. I couldn't really see if there's any other entry point to the cavernous sinus, like the inferior petrosal sinus. So it's hard to say. If there is, you could treat. I mean, first of all, I would treat it, given the retrograde venous drainage into the sylvian vein. I would probably go transvenously if you can get to the cavernous sinus from, say, the inferior petrosal sinus. That would be one way. If not, we've also done a few cases where you actually go through the superior ophthalmic vein, do a cut down, basically an eyelid sort of an incision, get down to the vein, and then enter the cavernous sinus that way.
Yeah, does any of you at your own institutions currently do an open approach when all else fails, or have you not had to do this at all with the advent of percutaneous, CT loaded on, image fusion and so forth? I used to do more of those. I published a series of 10 cases many years ago, but obviously with the advanced endovascular techniques, the open approach has become much less frequent. I don't know, any comment?
As you know, we're associated with the Wills Eye Hospital.
Yeah.
We see a lot of those, and we've published 2 big series. We've never had to do any open for that. Now, another thing, I couldn't see if there was any facial vein, because another way is to go IJ facial vein, SOV, and back to the cavernous sinus. Was there any facial vein, Henry?
Yeah, there was a facial vein, but right at the angular vein, there was a really severe tortuosity. So while you could probably get from the jugular vein into the angular vein, you would probably not get into the angular vein and get into the cavernous sinus. And also,
what about IPS, IJ IPS?
Yeah, there was no real significant IPS. The venous drainage from the cavernous sinus was solely to the sylvian venous system and also into the pterygoid venous plexus.
So the patient had generous SOVs, so I would go SOV.
On both sides, has bilateral SOVs on both sides, but there is, typically there is tortuosity at the level of the medial canthus that precludes you from going transfemorally from the vein into the cavernous sinus. But
so I'm saying I would go SOV direct.
Yeah, so that is no question an option going SOV direct. But you would definitely treat it, Pascal.
I'll treat it because, interesting, I'm showing a case similar. Those CC fistulas, it's very important to look at the venous drainage of the CC fistulas. When we say CC fistula, we all think, oh yeah, it's cavernous sinus. When those drain in the cortically and, for example, the superficial sylvian vein, we've had 2 cases presenting with intraparenchymal hemorrhage with no eye symptoms, and we diagnosed them with a CC fistula. So I would treat that, yes.
Intraparenchymal hemorrhage, but no CC fistula.
No. Intraparenchymal hemorrhage, but no eye symptoms. A CC fistula presenting with intraparenchymal hemorrhage, but no eye symptoms.
Right.
Okay.
Well, but that makes sense, correct? If they had anterior drainage, probably they wouldn't have had so much venous.
Well, I have a case they had both, but yes.
Okay. Anybody else on the panel disagrees with treatment or would do it differently?
I think it needs to be treated. I think with most of these, we try all of the safe transvenous options first, and then if after 30 minutes we're not able to get to the cavernous sinus, we use a cone beam fused CT and just puncture the orbital fissure and stick the vein, and usually those are pretty fast.
Yeah, that's the other route, is basically direct puncture. I think, Bobby, when you came over and visited us, I showed you how you can basically, in the angio suite, by doing a cone beam CT, you can create a target and an entry point, like you do, through the superior orbital fissure, and access the lateral aspect of the cavernous sinus directly.
Yeah, we would love to have that. We still have not been able to get that. It's akin to having stealth in the angio suite to line up your puncture, which certainly makes it nicer.
Yeah.
Is that what you did, Henry?
I am logging back in now.
Oh, okay.
Okay, so my computer has come back in, and hopefully your IT person will be able to. Okay,
Here we go.
I'm going to leave on my phone so that way. Okay, are you ready for me to?
Try share the screen, yes.
Now we know how Dr. Wu gets so much work done.
How's that?
You've got a body double. I mean, we just had proof of it a second ago.
What do you mean a body double?
There was two of you. There was two separate
No,
Henry Wus from two different angles.
I've got Tom Link, who is my another junior partner that just came in, and I got my two of the neurosurgery residents with me. Okay, so here you're seeing that ascending pharyngeal and the recurrent meningeal.
For moral support or what? Why are they all there?
Well, it's because we are supporting Jacques'
And
meeting here.
And they love to see a train wreck, which is happening right now.
Okay, so we went through the SOV. There's the catheter in this super. Can you see my cursor?
Yes.
Yes.
There is the catheter in the SOV, and there's some coils already now, and you can see the enlarged accessory meningeal artery that's going to it. This is a microcatheter angiogram in the cavernous sinus, and you can see the reflux into the sylvian venous system and the pterygoid venous plexus. This is the Eclipse 6L balloon. So there are two things. So number one, the Copernic balloon on the venous side is going to change the management of transverse sinus fistulas, because you can inflate that massive balloon in the transverse sinus and protect it from embolization from onyx that you are injecting from the arterial side. On the other side, there are two new balloons that are out, more than just the Scepter and the other dual balloon lumens that were present previously. This Eclipse balloon, while this middle meningeal artery is not necessarily so difficult to navigate, there are no questions like other intracranial arteriovenous malformations with much higher rates of with much higher degrees of tortuosity that are safely and easily navigable with these types of balloons. And you can see around the coil mass, and you can see the balloon inflated, and you can see the distal marker and the proximal marker. And this allows you to have immediate flow arrest. So that way your onyx injections are now, just a few minutes as opposed to potentially hours. So that is the onyx injection with the balloon inflated. And you can see now it's completely filling the rest of the cavernous sinus. Here is the external injection after the coils here and the onyx. Here is the internal carotid injection. You can see that there's no more filling from that recurrent meningeal branch. But
and sorry, where did you go with the balloon? Transarterial?
Transarterial into the accessory meningeal artery.
Okay, why didn't you do onyx from the venous side while you were already in the cavernous sinus?
Because I think that when you inject from the arterial side, while you have a backstop of coils in the cavernous sinus, you are more like, because you know that there are multiple other arterial feeders that are going to the fistula. You are more likely to then reflux back into those other feeders when you inject from the arterial side. Here's the
well, but it's a venous disease. If you shut down the vein, you're done. 50 cases, right. We already published a series, and now 50 cases coming out.
Here. So one of the other things about the cavernous sinus is that the cavernous sinus also has multiple septations. So the cavernous sinus compartmentalizes. And so here you can see that we've completely...
That's why liquid embolic, that's why onyx is the way to go in the cavernous sinus, because it goes all around and shut it down. That's why we haven't used coils in CC fistulas for the last 7, 8 years.
I mean, whatever liquid embolic that you want to use, or whatever embolic agent that you want to use to occlude the sinus is fine. I mean, I would have no objection to saying, hey, you can from this position go ahead and just inject onyx. That's a totally fine, legitimate thing to do. But in this case, with coils in the cavernous sinus acting as a backstop, that means that you have taken care of that compartment, and you don't have to rely on the random nature of the liquid embolic going into the various other compartments to ensure that you have sealed off the fistula. And I think that that's just like a, surgical preference, Pascal. I don't think that there's like any right or wrong way necessarily of doing it. And this is the left common carotid injection. At the end of the procedure, you can see the stagnation in the accessory meningeal, and you can see the preservation of the sylvian venous system and the pterygoid venous complex. That's it for my presentation, John.
Thank you, Henry. Let's stop sharing, and we'll have Pascal take us home with the last case. So I'm sure the audience is appreciating hearing all the different perspectives, the technical things, philosophical things, and that's why those sessions are so nice to interact with.
Okay, can you see my slides?
Yes, indeed.
All right, so this is last year. Jacques was photobombing me. He didn't even let me take a picture with my family. He was like everywhere photobombing the pictures. But
actually, your family begged me to be in the picture. That's fine.
Yeah, my wife wanted a good-looking guy in the picture, so she called Jacques. So this is, I'm gonna go quickly for the sake of time. This is a 50-year-old female with high blood pressure, presented with proptosis, chemosis, headaches for the last 3 months before she came to us. And then last month before she came in, she started having double vision. She was treated, as you know, those CC fistulas, sometimes they go all over the ophthalmologist and they treat them with eye drops and everything. And then somebody ordered an MRI, and the MRI showed some dilated SOVs. And then she went to an outside facility where she had an angiogram showing that she has a type D CC fistula. So this was her exam when I saw her. Actually, they were very different. What's that? Okay. So this is right ECA, AP and lateral. So as you see here, we don't see any dilated SOV, but we see early opacification of the cavernous sinus. No really big SOV. This is the ICA injection, AP and lateral, from the right side. And this lady, like the case that Rose showed, so they went and they injected a couple of drops of onyx proximally in one of the branches of the external carotid, and they told her, go, you're fine. So as we know, in type D CC fistula, usually it's mainly transvenous, not transarterial. This is a left ICA injection, as you see here, and you see the reflux into the superficial sylvian veins all the way to the right. This is an ICA injection from the left, showing the early opacification of the right-sided cavernous sinus and cortical venous drainage and drainage into the superior superficial sylvian vein. So at this point, there's no question if this needs to be treated or not. The lady is symptomatic. She has cranial nerve deficits, and she has also cortical venous drainage. And this is one of the cases, as I said, in CC fistula, it's really rarely you have cortical venous drainage, but sometimes you have. So she was symptomatic from both draining anteriorly. But what's interesting is we don't see any dilated SOV. Most likely they thrombosed. So this is a lady that doesn't have dilated SOV that we could see because most likely they are thrombosed, symptomatic from the eyes, and then draining backward. So our treatment options, in this case, no arterial option. I mean, the only arterial option, I think, in CC fistula is the type A, where you go transarterial, you find the hole, you inflate the balloon in the ICA, and you treat. So we tried the transvenous, couldn't go IPS, didn't have SOV. The only option that remained was just if percutaneous puncture of the cavernous sinus, what Henry and Bobby talked about earlier. But what we decided to do, because usually we don't do that, the majority of those fistulas, usually we are able to treat them one way or the other without, you know, puncturing the cavernous sinus. Because this lady had dilated and drainage into the superficial sylvian veins, we decided, so this is what they did at the outside hospital. They did drops of onyx proximally, that's what not to do, and then they sent her out. So we decided to go do a burr hole, guided burr hole on the sylvian vein and catheterize the sylvian vein, and this will be a straight shot to the cavernous sinus. So we tried transvenous, we couldn't, and this is what we did. So went on the right side, did the image-guided burr hole. Those are the arterialized sylvian veins, went with a microcatheter in the sylvian vein, and then with an 18 angiocath, then inserted a microcatheter all the way to the cavernous sinus and injected. This is how we treat our fistulas. We just go in with a microcatheter and inject onyx there. So this is my microcatheter going in, being navigated. This is the old onyx they did transarterial that you see here. That's my catheter. This is the system we have here. And then the injection of onyx, which is now a 2-minute case practically. We shut it down, completely shut down, removed it, and then some gel foam on the vein and some pressure, compression for 5 minutes, and we're done, and a burr hole cover. So we published this as a technical note in operative neurosurgery.
Ms. Corcoran,
This is
how you doing?
This is a case.
How you feeling?
Sorry, 1 second. I'm sorry, Pascal.
You look
Hey,
pretty
Greg,
good to me.
Greg, can you mute your
Big
phone?
surgery yesterday, and you're looking this good. That's great.
Hold on. Greg, mute. Yeah, thank you. Go ahead.
This is a previous case we published where a patient came in with an intraparenchymal hemorrhage, but didn't have any eye symptoms. And the intraparenchymal hemorrhage was the only symptom of the fistula. That's why those CC fistulas with cortical venous drainage are really needs to be treated. And I know some people will say, how come you're treating fistulas with onyx CC fistulas? This is our first paper. Now we have a 50-case paper that's got accepted in operative neurosurgery. This is practically how we're treating them. There's no increased risk of cranial nerve palsies. And if there is, at 3 months, they all recover. It's quick, and you don't have the problem of compartmentalization of the coiling, and the liquid embolic will go and find its way and shuts down the fistula.
Great. Thank you so much, Pascal. So everybody, we've seen all kinds of ways of dealing with fistulae today. We've covered many questions. Let me see. Okay, Pascal, question from the audience from Dr. Tan. In the absence of endovascular capability nor onyx, how would you suggest we treat this medically? Is there any other treatment? Pascal, if people have...
I mean, you know, anecdotal, you know, carotid, intermittent carotid compression. Can you hear me?
I hear you, yes.
Medical treatment for carotid cavity, well, this lady is very symptomatic. I mean, I would go do surgical treatment and pack her cavernous sinus before trying a medical treatment, because we all know that intermittent carotid compression isn't so efficacious, especially in those, you know, symptomatic ones.
I open it up to the panelists and to the speakers. Any last minute questions to each other, controversial points that came through? Luca, if you are still awake, I really thank you for staying up so late for us Any comments on anything?
Jack, only one
great
question.
cases, but
Only one question for the panelists and the speakers. People speak about the point fistulas in the CC fistula. And for me, it's very difficult to find the fistula point in the cavernous fistula. Do you think any experience? People speak that if you have one appearance initially in the early arterial phase, you can see that this is the fistula point. And for me, it's very important to know that, because like another sites, if you find the fistula point in the cavernous sinus, you go through that point. Do you think any experience?
You mean through that point transarterially, you mean, or transvenously?
No, it's only to find the fistula's point in the cavernous sinus fistula.
But does it matter, Alfredo, since you're going to most of the time go transvenously and pack the sinus?
But some people say that you have to be careful with the overpacking to the sinus, to the cavernous sinus.
Pascal, can you comment on his question?
I mean, I think in type A, yes. I mean, in type A, you go transarterial and you find the hole, and usually it's easy to find the hole. Either it's traumatic or a ruptured cavernous aneurysm, where you find the hole, then you inflate a balloon in the carotid, and then you do what you need to do. In all the other types, B, C, and D, I never even waste my time to look at the arterial side. I go from the transvenous side, and as I said, I mean, you know, I'm doing it with Onyx, and it's safe and it's fast, and it doesn't have any increased risk. And again, if you have a worsening cranial nerve palsy, the 90% of them recover at 3 to 6 months.
Yeah, Pascal, but you
why did you try to go to the other cavernous sinus? Because it looks like that was a left cavernous sinus dural fistula, which drains across the cavernous sinus to the right side and then drains out the right sylvian veins.
Well, I was able to treat it completely from the right side.
So there was no other venous drainage from the left cavernous sinus?
No, the only outflow of the cavernous sinus was the right-sided superficial sylvian vein.
Okay.
Yeah.
But there was no other outflow from the left cavernous sinus?
No outflow, no.
Okay, it's 7:32 p.m. Miami time. Fantastic session. Thank you for those who stayed awake, and meaning Luca, time difference. I thank you all. Have a great, Alfredo, thank you. Wonderful talking to you from Colombia, and everybody else. Thank you so much.
Thank you, Jack. Thank you.
Thanks, Jacques. Enjoyed it. Thank you very much. Have a good day.
Thank you.
Thank you.